Medical School, London. He's consultant at Royal Free UCLS Hospital, London, and fellow of Royal College of Ophthalmology, specialist. I'll just share my screen. Okay, you're already, no problem. You carry on, Dr.
Don't
Sir.
worry.
Specialist expertise in pediatric ophthalmology and strabismus. He's senior international examiner for Royal College of Ophthalmologists. He has authored almost 70 research index papers, 3 textbooks, and multiple chapters in various textbooks. He's also member of Council of European Strabismus Association and Scientific Committee of American Association of Pediatric Ophthalmology and Strabismus. So that's a huge list of achievements there and accomplishments. So over to you, Dr. Saurabh. His talk is Looking Beyond the Horizon.
Thank you, Dr. Swati, Dr. Rebecca, Dr. Amar, Dr. Pradeep Sharma. It's so nice to see so many friendly faces, and to Dr. Radhika and to Dr. Rohit for inviting me. It's great pleasure to speak at the RPC International, at the RPC Foundation Day, and I feel like a bit of a fraud because I'm not actually an RPC graduate, although it feels like that because the amount of time I spend hanging around AIIMS. So thank you all for being so nice and so welcoming to me every time I come. So I wanted to just talk a little bit about, it's a slightly unusual lecture. I just want to just a little bit talk about my career, what I've done, and some advice for some junior residents who might be wondering, like we all did, where should I go? What should I do? Where should I go for my fellowship? So I'm going to talk a little bit about my journey, what I did, a little bit about why, what's the pros and cons of doing a fellowship abroad, what does the UK offer, and a few ways to get there as well. A little bit about the exams because, that is what I do a lot of. So my journey in medicine, of course, started at MAMC, and I did my internship at LNJP Hospital, and I did my MS in GNEC. So it was almost seamless. How in medicine you get on a treadmill and then you just keep going. But then you come to a fork in the road, and the question then is, once you've done your MS or your DNB or whatever, then you do just then go on, you become a senior registrar, consultant, fellowship, or there's something else. And I wanted to do something a bit different. So I think the exams are in May, and I think in June I took the first flight I could, and I went to the UK to see what I could do with my career there. I have to say I didn't fly BA, I couldn't afford BA at that time. I flew the cheapest airline I could find. So that time in the UK, this is how it used to be. We started as a SHO, so I was very lucky. I got a really good SHO job at St. Thomas's and King, which are two of the teaching hospitals. And the key thing used to be the NTN, the national training number. So once you got an NTN, you knew you would become a consultant. Okay, that was their headache to make you a consultant. So you did your high surgical training with the NTN, and then people used to do one or two. So I did 2 fellowships, one in peds and one in adult strabismus and neuro, and then I became a consultant at the Royal Free in London, where I still am, and I was recently upgraded to professor because of my work with the UCL Medical School. So that's how it used to be. It's changed a little bit. It's in a way much better because you do 2 years of internship, F1, F2, and then you straight away enter ophthalmology for 7 years. So either you're in or you're out. That's good for the local trainings. What's not so good is if you go from India or wherever, it's very difficult to now enter the system because they've only got now 74 or 75 spots for the whole country. That's England, Scotland, Wales, and Northern Ireland. Okay. So why choose a fellowship abroad? I think, it gives you an opportunity to experience a different health system. Our residents at the RP Center are so fortunate. They've got all of you to teach them, and they already have access to some of the newest bit of technology. But I think a fellowship abroad exposes you to a new system, but also new ways of teaching, of learning, of mentoring. So, for example, for the strabismus and pediatrics, fellowship in my unit. Every Monday morning from 8 to 9, we have a 1 hour MDT where every patient going to theater is discussed. The fellow presents it, and they have to come up with a plan to say, I would do this much and this much on this and muscle. And then we all, 3 consultants come, we all talk about it. So it's a really rigorous way to test your decision-making process in strabismus, which, as you know, those who do peds and strap, probably the most important thing is knowing which muscle to do and how much. And that's why, I think the UK offers not just a global recognition because the UK training and RCOF qualifications are valued, but also access to a different way of teaching and learning. And unlike many other countries, most fellowships are actually quite well funded, so you won't have to starve while you're doing your fellowship. So there are two routes to which you can do that. And the key thing is you need to be registered with the General Medical Council. That is, because without doing that, you can't touch a single patient. So either you can do it like I did. So you do the PLAB exam, which is for general registration, and then you try and enter your training. Or I would, one of the key things is the dual sponsorship scheme, which is a new scheme, the alternative to PLAB, which is ideal for those with significant experience in ophthalmology, like the audience today. So that scheme runs for people who completed an MS, MD, or DNB. And what's really key, you must have been engaged in medical practice for 3 of the last 5 years, including the most recent year. That means you have to really currently in practice and have good English, which shouldn't be a problem. And what you do is you start with the job offer. So unlike me, who went on a tourist visa and then found a job, and then did PLAB, got tourist visa, found a job, and then moved to GMC, you go the other way around, which is much better. That means you find a job first, and then the people who employ you apply to Royal College for your sponsorship, and then you get GMC registration before you. So before you even enter the country, you already have a job in hand, and that's a much, much better way to do it. And that's what I would recommend. So if anybody's interested, you can scan the QR code. It will take you to the website, which tells you all about it. But the advantage of this is a structured training and mentorship program, which recognizes your Indian training. So you're not starting from zero. And it's also a streamlined pathway both for the GMC as well for the visa, and it gives you an opportunity to eventually gain a CCT, and I'll talk about that in a second. Okay, so what happens once you finish your fellowship, right? Again, there are two people sometimes do a second fellowship or a third fellowship. So there are quite a few RPC people. I have been privileged to assist in this route. So Toshet, Vashni, Sagnik Sen, Neha Yadav are the three people that come to mind. And once you finish, you can either do another fellowship or you can try and become a consultant in the UK. And there is another non-consultant route, which I don't think anybody from RPC should even consider. I think if you're in the UK, you should be a consultant. So one way to become a consultant is what I did. So you do your higher surgical training and you get your CCT. This is your specialist certificate. The other way, though, which is what you can do through this route, is do your fellowship and then you show equivalence in your training to what a high surgical training would do, and that's very, very possible. And if once you get to CCT, you can apply for a consultant job just as any local trainee, and it's been done by many people very successfully from India. As part of this, though, the exams are such unnecessary evil. So these are the 4 exams that need to be taken, because without these, you just will not get the certificate of completion of training. So of these 4 exams, the good news is all of them can be taken in India. I don't have to go to UK for any of the exams, and we hope to bring them very close to you guys very, very soon. Okay. So they're all delivered on the 2 written were delivered online, and the 2 clinical ones are done in India. So in Delhi, we'll be hosting them in October. We just did the Mumbai exams a few weeks ago. Okay. So the trend, the $1 million question is it worth it? Is it worth it to get the FRC off? The answer is very simple. It is if you're planning on coming and working in the UK. Otherwise, probably not. If you're going to work in the UK or abroad, it's one of the most prestigious qualifications and is the only way to get on the special register. So yes, absolutely. And also my plea, we need examiners. So we would love to have people like yourself, experienced clinicians as examiners. You can be an examiner 2 ways. Either you can take the FRC off yourself, or you can apply for FRC off by election. You've been a consultant for at least 5 years. And if you'd like to do that, please email me. I will take you through the process, and I'll be delighted to be a referee for anybody from RP Center to be a examiner by election. We don't pay you, but we do take good care of you. So it'll be great to have you. So challenges, it's always a challenge, visa and sponsorship, but a lot of these things I've already covered. The rest of the things I've written is actually the fun bit, adjusting to a new way of working, getting to learn, to look at the same things in a different way, and to understand how to, for example, document things differently. And that's the whole fun of it. So last thing we'll talk about is observership. So what if you was a way to try before you buy, and you can do an observership for free. If anybody from RPC wants to come, you just have to email. We'll be delighted to have you. But you better to come sponsored. So these two organizations give you sponsored observerships about $2,000 per month for 3 months, which is enough for your subsistence. And again, we try and say yes to every fellow who applies this route. Not everybody gets a sponsorship, but we do say yes to everybody. These are just some of the fellows we have had in the last couple of years from Turkey, from Pakistan, from India, and from Nepal. So these are some of the people in my organization. These are the various consultants who in the various subspecialties. So I'm just going to start. I don't know if there are any residents listening, but I feel as an older consultant, I feel I should give you some advice before I stop. So I will always say learning is a two-way process. You get what you put in. So you treat every placement, especially in a place like RPC, as a great learning opportunities. Take all opportunities as they come your way. If there's an opportunity to do an extra list, a new case, see extra patient, do it. Treat your juniors as you wish you were treated when you were junior, and they will always remember this. And the last thing I'll say is always do a little bit more than what's expected of you, and you will always be fine. So thank you very much for your attention. Thanks for listening. Those are my two hospitals. That's my university, and that's my address if you want to get in touch with me. Thanks very much.
Thank you, Dr. Saurabh. Thank you very much for showing part to our residents, part to UK and part to FRCs. That was a wonderful, informative talk, I must say. And if residents are listening, I'm not sure how many of them are actually listening, but if they're listening, it's a good way. It's their gate to UK. Thank you. So we move on to our next talk by Professor Pradeep Sharma, and he would be speaking about Duane's retraction syndrome. And as we know, sir doesn't need any kind of introduction. He is the strabismus as far as we are concerned. So over to you, sir, for your talk.
Thank you, Swati, for that resounding introduction. And I always feel part of RPC still. I haven't left it. And I don't know if it's, I'll just share my screen.
So you can't even leave it. You have left your legacy behind.
That's so kind of you. So let's have this entire screen window. Is it coming? I have to make it full screen?
Yes. Yes, sir.
Is it there?
So you have to make it yeah, now it's okay, sir.
It's okay?
Yeah.
So, Swati, so as you have mentioned, I'll be talking about management of Duane's retraction syndrome in 7 minutes. And I just want that some points would be considered for the strabismologist. I have no financial disclosures which are relevant to this. Most residents and people practicing know that Duane's retraction syndrome is also known as the co-contraction syndrome. And nowadays it is basically part of congenital cranial dysnervation disorder. It is seen frequently 1 to 4% of strabismus patients, and there is a female preponderance of about 60%. 80% are unilateral with a left preponderance. Embryogenesis is important. Now we are gradually realizing that it's the 4 to 8 weeks of embryogenesis, and some culprits are thalidomide and misoprostol by some studies. And there is a nice study by Parsa, which I would recommend people to read about, that higher estrogen level and inflammation in this period could be the culprit. And maybe we can prevent Duane's retraction syndrome if we can take care of these. So as I said, it's a congenital cranial dysnervation disorder. What we mean is there is a primary dysnervation of the sixth nerve, and there are certain changes which happen in the form of paradoxic innervation, and that is what creates a problem. So Duane's had described as type 1, type 2, and type 3, depending on the type of innervational imbalance which is there. But for clinical purposes, we will be classifying it differently. There are syndromes which are associated, like the Golden Haar, Klippel-Feil, Wilder-Wang, Holt-Oram, Okihiro or DRRS, and the IVIC syndrome. There are certain systemic associations which we should be also aware of when we are dealing with these cases. And there are ocular associations. Primarily of interest would be the crocodile tears, the gastro-lacrimal reflex, that the child is eating food and having tears, or the Marcus-Gunn jaw winking phenomenon, which may be associated and we may be overlooking them. So when we have a case of Duane's retraction syndrome, we will typically see that the eyes are having a deviation in the primary position. In this case, for example, there is an EZO deviation, there is a limited abduction, and on attempted adduction or inward movement, there is a narrowing of the palpebral aperture, there is a retraction, and upshoots and downshoots. So this is a typical EZO-Duane retraction syndrome. On the other hand, we have an exo-DRS in which the primary position there is an exo-deviation, and on abduction there may be some abduction, or some people may have limited abduction. On adduction, the features are similar. There is a retraction, narrowing, and upshoots and downshoots. How do we manage? Basically, the management is taking care of the paradoxic innervation which is there in these cases. And primarily, I would just like to limit that you have to focus on these points, whether there is an EZO deviation, exo deviation, or ortho in the primary position. Secondly, how much is the significant co-contraction? Co-contraction by definition is always there. It may be minimal or it may be severe. Then thirdly, on the table, you have to see force reduction test for both the medial rectus and lateral rectus, whether it is positive, significant, and that has to be taken care of. And finally, how much is the normal LR activity? Now, let's take some examples. This is an EZO-DRS in which the FDT was mildly positive. There was a minimal co-contraction. So in this case, what we choose to do is just a single left medial rectus recession of 4 mm. Now here, I would like to emphasize that minimum MR recession needs to be done. A little extra can be too much, and it can create a iatrogenic synergistic divergence, especially if there is a co-contraction which is severe. So like in this case, a 4.5 millimeter LMR recession created a synergistic divergence and had to be corrected by an LR recession. So whenever you have a significant co-contraction, along with the MR recession, always balance it with the lateral rectus recession. So here it is recessions of both horizontal recti, and on the LR, we will also do a Y split, which is splitting the lateral rectus by about 22 millimeters apart from each other, as well as 20 millimeters separation in lengthwise. So this corrects the problem which is there significantly. So in EZO-DRS, point to be taken home is these. In addition, SRT or a VRT or a vessel sparing partial VRT may be done, but it is only to be done if the co-contraction is not much or has been already taken care of. This is an EZO-DRS in which there is FDT free, minimal co-contraction, and just superior rectus transposition has been done, and this corrects the EZO in the primary position, adds abduction, but does not create too much of problem for the co-contraction. So this is fine. But otherwise, this is the algorithm for EZO-DRS, which can be taken from IJO 2019 issue. Some people have advocated doing a minimal LR resection. Now remember, this is generally contraindicated. It has to be taken with a pinch of salt, and only if required, do it minimally as Stephen Kraft has mentioned. In exo-DRS, how do we manage? You have to see the primary position exotropia. You have to see how much is the co-contraction and how much is the LR activity. If there is a normal LR activity which is there, then we do not want to sacrifice the lateral rectus. So we do not do periosteal fixation or extirpation of LR. We would just do large LR recessions or LR recession with a Y split. So that is the point to be noted. Never do differential recessions. When we were resident, we were taught that in Duane's retraction syndrome, you always do differential recessions. So in exo-DRS, MR recession was also done. This, I would say, should never be done in exo-DRS. No MR recession in exo-DRS. In exo-DRS, you do an LR recession, like in this case, of 12 millimeters with a 22 millimeter Y split alone, and that corrects an exo-DRS, exotropia in primary position, as well as the co-contractions, and that is good enough for this patient. And since there is a normal LR activity, we are not sacrificing the LR action by doing a more drastic procedure. A little LR recession is of no use. You have to do significant LR recessions, maybe sometimes 18 mm or even a periosteal fixation if the LR activity is not there. So in these cases, a periosteal fixation, for example, has been done. And to improve abduction, you may add on by doing a partial VRT. So an adjustable partial VRT can significantly improve the abduction. Now this case shows you an example, and this is a video of the same, that you have done an LR recession with periosteal fixation and a partial VRT. Exo-DRS cases which are having a small exo with upshoots, an LR recession with Y split, and if you want to improve abduction, you may do a modified Nishida procedure, which is a new addition to the transposition procedures. So a plus modified Nishida with a Y split leads to a good correction. And cases which have a marked upshoot, for example, in this case, instead of Nishida, one may choose to do a simple IR resection or a IR transposition. So this is what we have done in this Y split LR recession with an IR transposition to the LR, and that takes care of both the upshoot as well as the improvement of abduction. So these are some planning algorithms which you can again note it from the IGO, which was published along with Nipin Gaur's work. In ortho DRS, there is a challenge to maintain the orthotropia which is there in the primary position. So what we suggest is do an adjustable MR recession along with an LR recession Y split. So that is important to be maintaining the orthotropia in primary position as well as correcting the problems which are happening in adduction. So I would like to conclude here that in ESO-DRS, MR recession alone or with LR recession if there is a significant co-contraction. In EXO-DRS, one may do a large LR recession or a Y split along with, and only do periosteal fixation when there is no normal LR activity. In ortho-DRS, adjustable MR and LR recession with Y split, and to improve abduction, we may use SRT, IRT or a PVRT depending upon the primary position vertical deviation. The advantage of Nishidas is that there is no risk of ASI or anti-segment ischemia. Thank you all, and thank you once again for involving me in RP Center as ever. Thank you so much.
Thank you, sir, for that wonderful overview on management of DRS. So, sir, just one question before we move on to talk. So, sometimes in ESO DRS in residual cases, sir, we can do the other eye depending on the amount of deviation if there is residual other eye MRI sessions. What is your take, sir?
Yeah, so you can do the other eye, especially in ESO-DRS if the deviation is large, but the FDT is not very tight. So you'd want to do less amount of MR recession in the ipsilateral eye. But to correct the larger deviation, you may do the other eye, contralateral MR recession. Mind you, doing any amount of MR recession on the other eye will not create a lot of consecutive squint because the LR on this ipsilateral side is not working much.
Right, sir. Thank you, sir. If we have no further question, we can move on to next talk by Dr. Ankur, who would be talking about management of third nerve palsy.
Should I share my screen?
Yes, please.
So, is it visible now?
Yeah, but I think you'll have to make it a slideshow.
Okay. So, thank you, RP Center. Thank you, Swati, Dr. Rohit, and everyone. Thank you, Pradeep sir, for training us all. And it's always nice to be a part of RPC, whether we are physically or digitally. So I'll be talking in brief about surgical management of third nerve palsy. So we all know we have problems in the complete third nerve palsy where you have 4 out of 6 muscles which are affected. And it's difficult to bring the eye in center because there's virtually no action of the 4 muscles. The lateral rectus is pushing it out and the superior oblique is pushing it down. So such cases which have a medical cause like this case had in herpes zoster, so we tend to wait and sometimes we do get a good result. So this is a patient of the same patient which I showed you 3 months after the episode of third nerve palsy. The patient is fairly well recovered, as you can see here. This is another case of post-viral third nerve palsy, and we can see that the patient has fairly well recovered following the, we can see that the left eye is typically involved here, and following a waiting period of about 4 weeks, the patient has fairly well recovered. So we try and manage third nerve palsies in various ways. So we can do a maximal recession resection of the horizontal recti, either the same or the other eye. Can do a lateral rectus periosteal anchor along with the large MR resections. Can do a globe anchor to the medial orbital wall along with the large MR resections. And then there's a new thing which we have been doing lately is the transposition of lateral rectus to the medial rectus. So in incomplete third nerve palsies, R&R procedures can work whether in the involved eye or in the contralateral eye. So in this patient, we can see there is a fairly good amount of AD reduction in the left eye. So in this case of left partially recovered third nerve. So what we do is we plan a resistant resection of the same eye. That is the LR resection around 12 millimeters and MR resection by 8 millimeters. And we can see there's a fairly good alignment post-surgery. Now, this is another case where we have a good retraction of the lid when the patient tries to adduct. So this is a partial third nerve palsy with MR, good MR function with an aberrant regeneration. So the R&R procedure has been done on the left eye, and we can see that the right eye comes in, and the lid also elevates. So we can take the advantage of the aberrant regeneration in this case. So lateral rectus anchoring to the medial rectus, to the periosteal or the periosteum of the lateral orbital wall can also be done, because that is a strong muscle which is pulling the globe out. And you can combine that with MR resection to bring the globe more in center. So these are the photographs where the LR periosteal anchoring and the MR resection has been done. A fairly good amount of success can be achieved in these cases, but sometimes the superior oblique can spoil all the game because other muscles are actually virtually not there. So this is a case of another case of right complete third nerve palsy, and there is no MR function. There's a large residual exotropia despite doing a periosteal anchoring and MR resections. So these usually do not yield very good results because the LR can spoil the whole of the game, as we discussed just now. Another case of left complete third nerve palsy, we can see there is hardly any adduction or elevation. The eye is almost fixed. Now, such cases, we have difficulty in bringing the eye in center. So what we can plan is a globe fixation, that is anchoring the globe to the middle periosteum, medial wall of the periosteum, medial periosteum of the medial wall, which could be through a DCR approach or through a precurrenticular approach, or the globe can be fixed using periosteal flaps or fascia lata. And the other option could be a transposition of lateral rectus to medial rectus. So this is how the medial wall periosteal anchoring is being done. So we approach the medial orbital wall through the precurrenticular approach, and there is a small conjunctival bridge through which we go past our sutures to the periosteum, which is anterior to the laminae papyracea, and then we hitch the globe and pull it nasally. So we have to do a little bit of overcorrection because sometimes there is, or in fact most of the times, there is a slight amount of exotropia. So we aim at around 10 to 15 degrees of ESO immediately post-surgery. So this is a case of complete third nerve palsy, which we had shown. And this is following globe anchor to the medial orbital wall along with the lateral rectus recession. Another case of complete third nerve palsy where the LR recession and the globe anchoring has been done. So here we can see the right eye, which is having absolutely no function of medial rectus or any other muscle. So this is another case where the right lateral rectus recession by 12 millimeters and medial rectus anchor to the orbital wall has been done. Another case here, the ptosis was very significant, and we had to give the patient crutch glasses to improve the ptosis, but the patient had a fairly good alignment, at least in the primary gaze. Now, another option we have is to transpose the lateral rectus to the medial side, which is, which could be a complete transposition from LR to MR, or it could be a bisplit, and then transposing the LR to MR through a retroequatorial point. Or we can also add posterior fixation sutures to the inferior and the superior borders of the medial rectus, to the splits of the superior and the inferior divisions of the lateral rectus. And we can also combine them with the medial rectus surgery in terms of resection, because sometimes even with this, the results may not be as good as we want them to be. So medial rectus transposition was an old procedure which was lately popularized by Gopi Git and the group. So this is how the medial rectus transposition is done. This is a pictorial representation of same. So this is a case which I want to discuss. So this is left third nerve palsy. We have no force generation by the medial rectus, and there is some amount of perverted divergence because of the direction of superior obliques. So this is the lateral rectus, which is being split into two halves, and we have to split as far as possible, divide the belly into two equal halves, superior and the inferior, and we just go beneath the inferior rectus. In fact, we should be going posterior to the inferior oblique, and this is the superior oblique where the tenectomy has been done, because this also has a lot of effect in taking the globe out. So this is the superior part from where this thing has come, the flap of the muscle has come, and this is the inferior parts. And we also add a posterior fixation suture to augment the effect of the transposed muscle. So this is the inferior belly, inferior half of the lateral rectus, and this is the superior half of lateral rectus. which is abutting the medial rectus. And this is the post-op photograph. We can see there's a fairly good alignment, but yes, I wish we could have added a medial rectus surgery along with this for a better alignment. So this is the pre and the post of the same patient. So this is another a patient where FDT is to be done for adduction. It is very important to understand that if it's a very tight lateral rectus, it is not possible to transpose it to MR because there is a risk of pitting the muscle or breaking the muscle and losing the whole surgical option, whatever we had. So again, split of LR done and the MR transposition has been done. In this case, again, we can see a fairly good alignment. Now, in this case, again, LR to MR with the PTSO has been done because of the problems we can have with the PTSO, with the superior oblique overactions. Another case where a split LR to MR with PTSO and a posterior fixation suture, as I have just shown you in the video. So again, we can see a fairly good alignment. So factors, there are a lot of factors which can affect the surgical decision in the management of third nerve palsy. Whether first of all, we have to decide whether it is a complete or incomplete third nerve palsy. Then look for any aberrant regeneration and try and take advantage of whatever aberrant regeneration we have. Third is the patient is willing for the other eye surgery because sometimes you have to operate the other eye to take the advantage of the aberrant regeneration, and choose appropriate surgery. And then, let us see what happens with this patient. And sometimes we have to grade the surgical response with each surgery, and then finally think of what we can further add to the surgery or whatever we can do with in these cases. So LR to MR can have associated vertical deviations if they are not properly split. And periosteal anchor, we have to do an FDT to make sure that there's a good anchor to the periosteal wall of the medial orbit, and sometimes a resurgery may be required in these cases. Thank you for your kind attention.
Thank you, Dr. Ankur, for those wide array of cases of third nerve there and wide range of surgeries that you have shown us. So we have a lot of options for third nerve now. Initially, when we were residents, we did not have so many options. So LR anchor, LR to MR has definitely improved our third nerve palsy results.
And I feel, ma'am, that the last resort in all these cases when nothing works is the medial globe anchor.
Yeah, definitely.
So, yeah. Even when the FDT is tight for LR, we are not able to do complete third nerve palsies. You cannot do LR to MR transpositions. So LR periosteal anchor, and then in some cases it doesn't work, then medial globe anchor is the last resort that helps.
Yeah, definitely, Rebecca there. And so we now move on to next talk by Dr. I think Dr. Khokar has still not joined. So maybe we can take next talk by Amar, Dr. Amar, who would be talking about ASOCT, role of ASOCT in resurgeries.
Yes, ma'am. Thank you, ma'am. Good afternoon, everyone. Can you see my slides, ma'am?
Yeah, it is visible, Dr.
Yes.
Amar. You can carry on. Dr. Amar is assistant professor, associate professor here at RP Center, and he has done a lot of work on ASOCTs and their role in resurgeries. Over to you, Amar.
Yes, ma'am. Thank you, ma'am. So basically, I'll be talking on some of the imaging modalities, that is nothing but OCT, so which we can use in strabismus resurgeries, because we can see the normal muscle also, but it's not going to make any use if you are using in normal eyes, where anyhow you are going to explore the muscle. But it becomes important when you can use the tool as a guide for your surgical experiences. So basically, we consider imaging in strabismus just for like two reasons. We want to understand something physiologically. It could be muscle dislocation, polyheterotopia, intermuscular septum changes, and high myopia. So in those cases, we do MRI or CT scan just to understand the anatomical parts of the muscle. And second thing is we want to look for the muscle insertion where we are going to operate in all the eyes. So you can consider UBM or ASOCT, but the limitation of UBM is it's a contact procedure and you can scan along only one axis. The advantages of ASOCT is it's a non-contact procedure and you can take a good number of scans. You can take even 5 or 10 scans along the width of the rectus muscle, because the rectus muscle has around 8 to 10 millimeter widths in any given recti. So you can scan at multiple levels and we can measure the distance from the angle just to locate the muscle. So this is how we are going to localize the muscle. Here on this side, left side, you can see if patient is abductive, you can take the scan, right? So you can see the muscle, and here in the down left, you can see that is a lateral rectus muscle. And here it is the inferior rectus muscle and the superior rectus muscle. So how to identify a normal rectus muscle? So this is an eye or a virgin eye where no muscle surgery has been done. So you can see that once you take the scan, you can see the ocular coat is quite regularly convex. It doesn't have surface irregularity. So this is a virgin eye or an unoperated eye. So that's why we need to look for ocular contour. So second thing is, what is the depth of the hyporeflective layer? So the muscle is going to be just lying on the sclera. So it will have a definite depth from the ocular surface because it's going to get inserted onto the sclera. So it begins at some point, and after that, it's going to assume much thicker and darker complexities. So this is a tendon, and as you go posteriorly, you are able to see the muscle belly. Of course, we won't be able to say which is the tendon, which is the belly, but we can say that this is a point where the rectus muscle has started its insertion. So that is a depth of the hyperreflector, which is around approximately 40 to 50% depth from the surface. Intensity. So it should be having a minimal darker complexity because it has tendon, and the belly is going to have much thicker, darker complexities. And it should not be visible in bits and pieces because sometimes we can see subcontinental spaces, there could be cyst or there could be fluid collection. That is important in resurgeries. I'll show subsequently those pictures. So if you are able to see something which is hyperreflective at mid depth, but it's not continuous, so obviously that cannot be muscle. So muscle should be satisfying that it is appearing at 50% or 60% depth and it is continuous. So while scanning, we need to make sure that because muscle has the length and the width. So here in the left side, left video, you can see that whatever the scan I have, so I'm scanning vertically just to know the horizontal width of the muscle. On the right side, you can see that I'm seeing the vertical scanning just to understand the length of the muscle. So when you have plus scanning, you can scan the lengthwise and the widthwise. So that's how you are going to understand the two-dimensional picture of the muscle. Here on the left side, you can see that this is a transverse scan. So which is basically indicating the width of the rectus muscle. Sorry, this is the length. On the left side, you can see that angle is there. So this is the length. So this is a anterior red arrow is the insertion. And as you go posterior, this is a congenital fold and the muscle is getting disappeared. So this is the lengthwise scan. So if I put a caliper from the angle to the anterior row, this gives the distance from the angle or the limbus to the muscle insertion. So if I take a horizontal scan along the inferior sclera, I'll be able to see the width of the muscle. So width, as I said previously, it is around 8 to 10 mm. So you can see that we are able to see the width and also the length of the muscle. If you correlate these two findings, the lengthwise and horizontal widthwise imaging, so then only you are able to see the muscle more appropriately. So how to identify the operated muscles? So you can see that, as I said previously, 4 criteria. And you can see the ocular coat contour. First criteria, it is not perfectly convex. You can see there are like irregular areas in the anterior portion. It is quite thick and posterior it is thin, because once the muscle has gone posteriorly, the ocular coat becomes thinned out. So this, you are able to see that the red arrow says that possible insertion was here, that where the muscle insertion was there. You can see the stump, and thin ocular coat indicates that the ocular coat has become thinned out because muscle has gone posteriorly, and we are not able to see any hyperreflective area at around like 50 to 40% depth. And of course, we can't comment about the intensity or continuity, but I can say that further posteriorly, there could be some hyporeflective area, there could be muscle here. So once I measure the distance from the angle to the insertion, and then from the insertion to the visible muscle, I can comment that, okay, probably 4 or 5 or 6 mm MR recession has been done. So similarly, you can see that again, the first criteria, the ocular coat contour is quite irregular. You can see one bump here, one bump here, because once you operate the eyes, the surface becomes irregular because of congenital scarring, right? So this is how we are going to identify, we're going to comment that, yes, this is not an eye, this is an operated eye. And of course, we are able to see the hyperreflective layer, which is around 40 to 50% depth, and it is quite thick. As I said previously, the tendon is going to be very thin. So it appears that it is very thick. So it could be medial rectus muscle dissection, which has been done. And if I want to open the conjunctiva just to research this muscle or just to explore, I'll be able to find this muscle around 6.5 mm from the limbus. So this is a lateral rectus muscle of the same patient. You can see that the right eye control. Whenever you are doing OCT, you need to take the same patient's other eye muscles as a control readings, right? So in this case, you can see that the right eye has a unoperated or a good visible lateral rectus muscle, untouched lateral rectus muscle. In the left scan, you can see that this was the possible insertion, and you can see that the ocular coat contour has been lost and it has become thin, and I'm not seeing any hyporeflective layer in the anterior portion just beneath the insertion. And there are like minimal congenital scarrings are there, but definitely I can see the muscle much posteriorly. So if I measure the distance from the insertion or like whatever the original stump is there, from that portion till this portion, I will be able to comment, okay, probably 9 mm or 10 mm recession of the lateral rectus has been done. So similarly, this is another picture of the another patient. You can see on the right side diagram, whatever the 6.9 mm reading says, this is the normal eye. Okay, this is unoperated lateral rectus muscle, which is indicating that that patient's unoperated eye lateral rectus is at 6.9 mm. If I want to compare, I don't need another patient scan. I can compare with the same patient. And in the left side diagram, you can see that I can see some amount of surface irregularity, but most importantly, I can see that the muscle is quite thick. So it indicates that probably it has been operated, and the thick portion is because the tendon has been resected and the belly has been positioned at the insertion. So this is a resected lateral rectus muscle. So this is how we can garner the information regarding whether the muscle has been recessed or resected. One more clinical important condition is because we all do muscle surgery, sometimes muscle can be slipped. So it could be traumatic or surgery induced also. So in this picture, you can see that there was a young lady who presented with traumatic squint in the left eye. She had extra large angle exotropia in the left eye. The eye was not adducting, and you can see the MRI picture. Here you can see that medial orbital wall is fractured, and there is some discontinuity along the medial rectus muscle, but it has maintained its strength. So probably it is lying somewhere on the ocular coat, but I can't comment that using the MRI. Either I can go for exploration, but you can just do one non-contact imaging, that is ASOST. You can see here, I can see the faint muscle here, which is quite anterior. Probably it is in subconjunctival space, but I can see it is there, and it is quite regular, and it is continuously visible. So distance is around 11.4 mm, which is from angle. So the distance between discrepancy between the angle and limbus is going to be around 0.5 mm. So if I want to open the conjunctiva, I can be sure that I will be able to find the muscle somewhere between 11.5 to 12.5. So that's how I can mark from the limbus here. And then I can open the limbal conjunctiva or pharyngeal conjunctiva. Then I can directly hook just beyond the 12 mm mark. That's how I can retrieve the lateral rectus muscle. See, you can see in that capsule only, using the ciliary vessels, we are able to identify the muscle, and we are able to advance it along with lateral rectus recession. So we achieved orthophoria. Most importantly, when you advance the medial rectus muscle, you'll be able to give duction, which is more physiological rather than vertical rectus transposition. Another thing which we have said is like combining the ASOST and CT scan. So this is one patient who had a road traffic accident in the left eye, and you can see that he had a severe amount of hypertropia, and he had good vision. He had significant diplopia, and lower lid notching is also there. And you can see that because of IR injury, there is a lack of infraduction. So we did CT scan. We are able to see that this A picture subsegment says that this is a right inferior rectus. In the left, you can see that I can't see the IR, but if
Dr.
I see
Amar, I'm sorry to disturb, but I think we are running late. Maybe you will have to wind up the talk.
Yes, ma'am. So this is how we can
Thank you.
combine the CT scan and ESOC picture, and you can explore the IR, just placate the IR or advance the IR and recess the superrectus muscle. That's how you will be able to correct the vertical deviation also. This is another example. So that's it. You can use ASOST in resurgeries and also muscle slippage, traumatic or surgical induced. And you can combine the ASOST plus CT scan MRI finding just to enhance your surgical planning. Thank you.
Thank you, Amar. I think that's a very good addition to your day-to-day strabismus practice, especially in these cases, as you told, recurrent and traumatic cases.
Yes, ma'am.
So yeah, so those tricky cases that can guide your management. So I think since we are running short of time, I quickly move on to the next talk. And Dr. Digvijay, so your talk, I would like to invite you for your talk on myopia risk factors.
Thank you. It's a pleasure to be presenting at the RPC Foundation Day. Are my slides visible?
Yes, sir, it's visible and you're audible.
Right. So I'm just going to talk briefly about the risk factors for myopia. Myopia, we know, is something that's of late gained a lot of interest because it's become like an epidemic or a pandemic in some ways or the other. And now there are a lot of factors, risk factors that have been associated with myopia now, among which is the genetic aspect, the first aspect. So we've seen that there's a gene-wide interaction. Interaction studies have shown that a lot of polygenic inheritance, multiple genes, almost 25 plus genes for primary myopia have been associated. For secondary myopia, it's still a monogenic inheritance, but there is a gene-environment interaction that actually tends to play the more important role in these cases. And so, of course, we've seen that if there is a heritability in myopia, and that's because of these genetic risk factors. Age-wise, we know a younger onset of myopia is likely to be associated with a higher myopia later on in life, and we know that it progresses rapidly in the age group of 6 to 11. So there is age as a risk factor, and the age of onset also may influence how the myopia treatments work for these cases. In terms of gender, we know that gender differences are there, and females tend to have more myopia, but these start after the age of 9 years. These cases, probably it is to do with puberty and other changes that are happening, as well as we found that they're spending a lot more time indoors in terms of the females as against the males who are spending more time outdoors, and therefore there is a predisposition there. But in a certain set of Jewish boys, it is been found who was spending more time indoors, the Orthodox boys, that the boys actually had more myopia. So therefore, the environment does play probably a bigger role than some of just the gender factors alone. Parental myopia, as I said, very, very important role. It is heritable, two-fold increase or even up to threefold increase if one parent has myopia, and a 3 to 6-fold increase in the risk of myopia if both parents have myopia. And this is again something we notice even in our day-to-day practices. Ethnicity-wise, we know East Asians, South Asians tend to have more myopia, higher myopia, faster progression as compared to the Caucasian population. And in progression, the East Asians tend to progress faster than the Europeans, and the East Asians also tend to progress faster than the Indians, almost at double the rate, at about 0.6 to 0.7 diopter per year as against the 0.3 diopter per year that the Indians would be doing, or South Asians. The baseline refractive error, again, is an important risk factor. And so if there is lesser hyperopia at a younger age, normally we would see all children to be hyperopes, then there's a higher chance of myopia. And over time, studies have shown that if you're 0.75 hyperopia or less in class 1, or 0.5 or less in class 2 to 3, and beyond that 0.25 or less in classes 4 to 6, you're more likely to get myopia as a child, in the childhood, as compared to somebody who was hyperopic at that age group. Though again, these are from different follow-up studies that have happened in different populations. But baseline myopia does influence the final outcome in terms of the myopia treatment and progression, both ways. And environment plays a very, very important role as well, which is visual environment. So we know that a major contributor is spending time indoors or near activities. Outdoors is actually protective. So children who are spending 2 hours or more outdoors are well protected from myopia, but we want 40 to 120 minutes of outdoor activity every day. Near work, more than 45 minutes at a stretch, less than 20 centimeters distance. So the closer it is, the more it's likely to create a myopic effect. So environment is important, and therefore these are the modifiable factors that are there. The other environment is the education. We've seen that children who are more educated or have a higher degree, who have probably spent more time studying, are likely to be more myopic than others. And similarly, it is also to do with children who have been extensively engaged in tuitions or other classes after school. Higher exposure to screens also is a part of this. And higher academic degrees have been associated with a higher risk of myopia or a higher amount of myopia, both. We know accommodation anomalies, such as accommodation lag or a high AC by A ratio, or presence of phorias. Esophorias have a higher risk of myopia going forward. So therefore, these are anomalies that again we can correct and try to prevent the progression of myopia. A lot more factors such as physical attributes of somebody, whether he is, in terms of height, somebody who's gained a lot of height suddenly, or lanky and tall, is also likely to have myopia progression as they gain in height going forward. Things like history of low birth weight, prematurity. So these are also sometimes causes for myopia. Now, the changes that we recommend that we do to take care of these or to prevent progression of myopia is to reduce the near activity, less than 40 minutes at a stretch, at a distance from you, more than 20 centimeters distance, to spend 2 hours of outdoor activities every day, keep good lighting, 3000 lux or more, so that's good indoor lighting should be there. You should avoid, saturated fats. So diet, again, these are soft things that you can do, but the diet has to be important. Diet which is high in cholesterol or saturated fats is to be avoided. Sleep and circadian rhythm is very important. So make sure that there is proper sleep that the child is doing or you're being able to do, because sleep and circadian rhythm again has been associated in studies, even in chick eyes and non-human, as well as in humans, there have been risk factors that they've been associated. So all this together, is what constitutes the risk factors for myopia. And I will leave about a minute for discussion because I think Dr. Rebecca can also pitch in. She's been doing a lot of work on myopia.
Thank you. Thank you, sir. It was a wonderful overview. Actually, these risk factors, as it's been very aptly described, that genetics is the gun, but environment is the trigger. So it's a complex interplay of genetic and environmental factors, and lots of research related to it. And I think most of the factors we have still not been able to elucidate or understand the mechanism. But very important to understand is that you have to introduce these lifestyle modifications as the first and primary treatment. Now, talking about treatment, I think we can move on to the next talk. If our panelists have some comments, then I would welcome them. Otherwise, we move on to the next talk. The next would be by Dr. Jasprit Sukhija on understanding the role of atropine, the most accepted intervention in myopia. We can see your screen, sir.
Yeah.
So you're
Am I audible? Yeah.
Yes, you're audible now.
Yeah. So first of all, thank you, RP Center, and thank you to the King of Myopia who I'm missing in this webinar, Rohit. And thank you, Swati and team, for inviting me to this webinar. And moving on from where Digvijay left, probably, yes, we need a lot of interventions to prevent children going into high myopia and having all their complications. So just one of the intervention is using the low-dose atropine, which has been studied quite a lot. And we have various studies now from India as well as from the Western world. And I'll be discussing some of that, how it's been helpful over these years. So, yeah. So we have different ways of controlling myopia progression. One's environmental modification. Yes, it's a lifestyle disease, as was rightly described by Digvijay. I mean, a lot of factors coming into play in the environment. You have pharmacological therapies to support them, and you have optical correction. So I'll just be touching upon the pharmacological therapies here. So many trials have been done on the role of atropine in delaying myopia progression. So even though the mechanism is not well understood, I mean, some say it acts on the sclera, reduces remodeling, some say it binds to the muscarinic receptors on the retinal amacrine cells, and some say it has an anti-inflammatory effect. So we are still not clear like how it's working, but yes, it's working wonders. Now we have different concentrations which are available. So how do we choose the correct concentration? I would be talking on low dose, that's 0.01%. So what it should be effective in slowing myopia progression. That's the foremost thing we want. It should not have much side effects like photophobia or near vision difficulties, because atropine is known to dilate the pupil. And third, if we have to stop it, it should not have a rebound myopia, which is significant. So there are some of the important studies which have been done on 0.01% atropine, which it all started in Singapore with those randomized trial where they use higher concentrations like 1% and then moved on to 0.01% and which is still ongoing in the ATOM-3. The LAMP study, again, they use 3 concentrations and they use it for almost 5 years. The CHAMP study where they used 0.01 and 0.02%. And of course, Rohit has shown wonderful results by using 0.01% in his study. So if you see, we can just talk about 0.01% at the moment, because if you see these you can see the size of these green circles denote how many studies have been done. What is the percentage of studies? So if you see 0.01% and if you see the refraction change versus with their controls, this is the one which we can talk about. Many studies have been done, whereas with the other ones, there are very few. And the thickness, of course, denotes how basically it's a direct comparison about, again, the number of studies which have been done. So if you see the refraction that has been compared, it's there. If you see the axial length, again, is being with the controls, is being compared with 0.01%. So basically, I'm going to cover 0.01% because that is what we have a lot of evidence for. So this was one of the important studies where they have randomized the children in using the 3 concentrations, 0.05, 0.025, 0.01, and they had a placebo group. And basically what they found was the reduction in myopia with 0.01% was about minus 0.59 diopters as compared to 0.81 with the placebo, which was significant. So the reduction in myopia progression was quite significant, whereas the reduction in axial elongation was less, but not that significant. But yes, what happened when they compared it, it was that it was a concentration dependent effect. So higher the concentration was having a more effect as compared to the lower concentration. They did not measure rebound, and that was the drawback of the study. So if you see the ATOM-2 study, again, the 5-year results, in year 3, they stopped all treatment and they found that greater rebound effects were noted with higher concentration. And in all these groups where they use different concentration, they started 0.01% in all these groups. And after 2 years, what they found was those with 0.01% initially. So in this group, when they had different concentration, those on 0.01% had the lowest overall refractive progression. And they then suggested that this 0.01% is clinically more palatable. And then again, coming to this big meta-analysis published in JAMA, almost 19 studies where they found atropine to be effective in slowing the progression of myopia. They did not find any difference in the doses of atropine within this range. Higher doses were associated with more adverse effects. So now, because adverse effects were less frequent with lower doses and higher doses were not more effective, because they had found in these studies, they concluded that using atropine at lower doses to reduce the progression of myopia was fairly effective. Now, how is the progression of myopia on 0.01%? Well, rapid progression was seen in 18% at 2 years, and in the LAMP study, almost 28% at 1 year. Now, this is one of the recent studies published in the Indian subcontinent. And of course, Rohit saw that at 2 years after starting atropine, there was a mild progression in 87.7%. So most of them had just a very mild progression, and a very few had severe progression. And even though they had rapid progresses in their study, they found that there was a 17.4% reduction in them within 2 years of atropine therapy. So it was fairly working well, the 0.01%. So why are these conflicting results? Indian studies found a good outcome, whereas the Western population have not found significant results. So one of the reasons could be that the atropine binds to melanin in these darker irises, results in slower release and longer active time for the drug, which may yield higher efficacy in these Asian children. So that would be one of the important reasons why you have seen a good effect with 0.01% atropine. So the WHO now, because it's been widely used, they say treat the children for 2 years. If you have good response, that means no myopia progression or very less over second year, taper and stop. If you have moderate response, continue for another 1 to 2 years. Well, if you have a poor response, the child may be a non-responder, or one can consider alternative therapies. So what to expect when you start low-dose atropine? There could be some progression in the first 6 months, which could be, then progression could be around 0.5 diopters per year. And it differs in younger children and fast progressors. So the age is very important when you start this progression. The risk factors like family history are another big, you can say, risk factor where you find that the 0.01% may not be effective as compared to a child without those risk factors. So how to taper atropine? Well, there are no guidelines as yet. We all know that we start atropine and we need to stop it after a while, maybe a couple of years. So one could just alternate it for about 3 months, then maybe once a week for the next 3 months. Of course, one needs to be very careful, very vigilant in younger children and fast progressors. So just summarizing it, what's the ideal concentration of atropine to be used? Well, I will be talking just about those evidence-based treatment trials which are available. 1% was initially used. They found it effective, but had bothersome side effects and a high rate of rebound myopia. And if you see this 0.5 and 0.1%, again, they were effective in slowing myopia progression, but they had rebound myopia and side effects. 0.05%, most effective low concentration atropine with tolerable side effects. So they've seen it for 5 years, but the problem is we don't have data on rebound myopia. And so we are still left with 0.01%. What we have now is what we feel is the ideal concentration. It's the most effective concentration at 5 years with least rate of rebound myopia and minimal side effects. So although it is atropine efficacy is all dose dependent, but side effects are again one of the reasons why probably it's not that common to use higher concentrations. So I'll just conclude here by saying that the low dose atropine is 0.01%. Till now is the only approved drug for myopia control. It's a well-researched drug with known efficacy. Side effects are negligible and works well in the Asian population, being cost-effective and without significant rebound. Thank you so much.
Thank you, sir. I think very beautifully summarized everything about atropine that we should know. And I think you would agree that 0.01 atropine works in most of the cases in Indian children, but rapid progressors is somewhere where we struggle. Although the rapid progressor percentage is less in India. And in those cases, I think we have tried recently, AIIMS study was published by Dr. Rohit, where 0.05% atropine did pretty well. And otherwise, we can consider other options like spectacles, although 0.01% is a very safe, effective, affordable, and easily available intervention for myopia.
Yeah, absolutely. I agree.
Thank you, sir. Now, changing the gears and moving to pediatric cataract management. So for that, I think I would like to start with Dr. Ashwini. He would talk about the evaluation of pediatric cataract.
Good afternoon, one and all. Ma'am, my screen is visible?
Yes, Ashwini, you are audible and visible. Yes.
Thank you, the organizing committee. Thank you, Kukur sir. Thank you, Chief RPC, for giving me this opportunity. Thank you, Swati ma'am. On topic that is evaluation of pediatric cataract. There is no financial interest. Whatever little I know in the field of ophthalmology, I always give credit to my alma maters, my teachers at RP Center. So, the evaluating a case of pediatric cataract can be divided into pre-operative, peri-operative, and post-operative. Will define into 3 different categories, and post-operative will again part into early post-operative evaluation and late post-operative evaluation. So, if you come to pre-operative evaluation, first is history taking. So, a detailed history, including family history, is most important. History of onset of the lenticular opacity, laterality, the progression, a prenatal history also, whether they have any mother use any drug or febrile illness with rash like chickenpox. Birth history, especially birth weight, and development history need to be assessed. Once the patient get admitted to the ward, because most of the cases are done under general anesthesia, pedigree chart need to be drawn. Now coming to the visual acuity assessment, in case of pre-verbal children, the fixation behavior like central, study, maintain need to be assessed. And the objection to occlusion is one of the very important tests that need to be performed. A red reflex test like this in a dark room can be done with a simple diet of thermoscope, because sometimes without red glow, we need to do surgery. Asking about visual interaction of the child at home with the family members helps in determining the severity of visual dysfunction. Sometimes the parent will complain, the grandparent will complain that the child is not coming to us whenever we call them, so that need to be assessed. In case of older children's preferential looking tests like Cardiff, K-chart or Lee symbol need to be done. Posterior segment evaluation by indirect ophthalmoscopy and ultrasound by USG should be done. And morphology of some pediatric cataract cases need to be known, because some morphologic cataracts like oil drop cataracts, sunflower cataracts associated with some systemic diseases. By looking at the morphology of cataract, we can know the other part. We can do the systemic investigation also. There are 50 images of pediatric cataracts. Now coming to the investigation part, the unilateral cataract generally not usually any investigation needed, but if the child have other associated symptoms like microcephaly, deafness, the torch infection need to be done investigated. In case of bilateral cataract like jaundice, in case of child with other diseases, the detailed evaluation need to be done. Now coming to the perioperative evaluation before surgery, the perioperative workup like pursuit of light, the fixation like central study maintain, ultrasound, and screening of the parents is also very important. The size of cataract, site of cataract and laterally, which right eye, both eye, and abnormal movements associated with it like strabismus, microphthalmus, secondary glaucoma, subluxation or dislocation. Now coming to the intraoperative biometric measurement, this comes under also evaluation part. The immersion scan, A scan need to be done in case of children's. The surgeries need to be done under general anesthesia. The source of error here are corneal compression, or under GA there is no fixation, or if there is squint, there might be some error. Keratometry measurement done by handheld keratometer. The source of error is like speculum. KM should be performed before application A scan, or we get a wrong keratometry. Or during UVA, you do axial length, keratometry, and corneal diameter and white to white. There are some exams like total cataract or membranous cataract and Morgan cataract in case of children's. The indication of surgery, the evaluation, why we are doing an evaluation to do a surgery or not. So the surgery should be done in a visually significant cataract more than 3 millimeter, or if there is opacity at the posterior pole or associated with nystagmus or strabismus, or if there is with the direct ophthalmoscope, there is in undilated state, there is a obscuration to the globe. The timing of surgery, generally in unilateral cataract 4 to 6 weeks, and bilateral cataract 6 to 8 weeks. In symmetrical cataract, second eye done is within 1 week. And symmetrical unstable patients, both eye can be operated at the same sitting. With less than axial length, less than 17 millimeter, and white to white, less than 10 millimeter, we don't implant IOLs. The IOL power calculation is also very important in case of perioperative evaluation. There are different power of different criteria, so Dahan's criteria, Post criteria, NAT criteria, and Dr. Coker and et al. Criteria. Mostly I follow more than less than 6 months, we do 20% under correction, and 6 months to 1 year, we do 15 to 10% under correction. And at the age of 2 years, we do 5% under correction, and 5 years, 2% under correction. Now coming to the early post-operative evaluation, which is very important, because it's not, if you just do a cataract surgery, it's just a cosmetic cataract surgery. After cataract surgery, the remaining 50% of the part need to be done. So before operating the other eye, the refractive status of the operated eye need to be done on table while operating on the second eye on the next OT. And in the follow-up, we need to follow up on the first week, 6 week, 3 months, and every 6 monthly. And after 6 weeks, we need to suture removal, do a IOP and fundus and diffraction, and 3 monthly again the same assessment and with the vision assessment. And every 6 months, we need to check whether the patient getting myopic or if need glasses or not. Visual rehabilitation is one of the most important part after cataract surgery. The refractive error need to be corrected. Prescription of glasses, prescription of contact lens, or prevention treatment of amblyopia is very important in case of unilateral cataracts. So glasses less than 2 years we give for the near correction, because the child is focusing mostly on the near things, mother or near work. If more than 2 years, we give executive by class with emetropia with +3 near eye. The fellow eye, if phakic, that also need to be treated, whether it is hyperopia, myopia, astigmatism, or any esotropia is there or not. Amblyopia management need to be done. Rigorous amblyopia therapy need to be given in unilateral cases, and surgical correction of squint when indicated need to be done. Late post-operative evaluation also very important, because with time, visual axis opacification is extremely common complication. Is most common complication in case of pediatric cataract cases. So in these cases, membranotomy might be needed. Again, the other complications like glaucoma, retinal detachment need to be ruled out. And at the end, the stereopsis test like frisbee, Randot, and Tishmer's fly, as Professor Padisarma says, without binocularity, if you just give a cataract vision, that does not make sense. So binocularity need to be there for a child at the end of any cataract surgery or in squint. So at the end, I like to thank my mentor and guru in the field of cataract surgery, Professor Coker sir and Dr. Titial sir. Thank you. Thank you so much.
Thank you, Ashwini. So I think, yes, the most important part I think every step is important, right from the early identification to IOL power calculation to early intervention, and most importantly, the post-operative rehabilitation and follow-up. So we need to counsel the parents that the follow-up is really important, especially taking care of amblyopia in unilateral cataracts. So now moving on to the last talk of the session by Dr. Anuradha on IOL implantation in pediatric patients. Dr. Anuradha.
Thank you, Radhika, for giving me this opportunity to speak in this auspicious day of RPC Foundation Day. So we will be discussing how IOLs should be given, why they should be given, when, what, which, and some special cases. I hope I am audible to all.
Yes, ma'am, you're audible. Yes.
So why? Because the primary implantation is the most physiological way you can rehabilitate a child, but at times you may have to plan a secondary implantation. Unilateral cases, we would be aggressive and will be implanting the IOL at an early stage. So now, as we are moving on with better techniques, we are implanting IOL at an earlier age. Earlier, the teaching was that at 2 years of age, you are putting an IOL. Now it has come down to 6 months. And now in BJO, there is a study which is showing that after 3 months of age, you can put an IOL very safely. The only problem is the visual axis opacification, which is always associated with IOL implantations. But there are cases where you wouldn't go for a primary IOL implantation like microphthalmia, microcornea, when the corneal size is less than 9 millimeter and the size of the eyeball is less than 16.8 millimeter. So what are the different choices? We have multiple choices. You can have single piece, multi-piece, hydrophilics, hydrophobics, torics, multifocals, EDOFs. But what we need to remember is, as Coker sir has told us that EDOFs and multifocal IOLs can be done only in special cases where the child is at a higher age group, like more than 8 years of age, has a traumatic cataract. You know the other eye is physiological, and if you don't give a good lens in this patient, then this eye will be always compromised. So, but in other cases, you won't go for a EDOF or a multifocal, because as the age grows, there will be change in the refractive status, and this IOL is going to be a problem for the child. So when whether to give hydrophilic or a hydrophobic intraocular lenses, obviously hydrophobic is better. You have a square edge, the PCO formation is less. But there is a recent study from Sadhguru Netralaya which tells us that they give comparable visual and surgical outcome if you do a PCC and anterior vitrectomy in every case. So secondary IOL implantations, there are times when you may have to go for a secondary IOL implantation. The idea is to give in-bag implantation of the single piece IOL, but at times there may not be a good sulcus and good bag, and then you may have to give a ciliary sulcus fixation. In some special cases, you may have to go for scleral fixation with or without sutures and anterior chamber intraocular lenses. We will come to that later. So which IOL power, as Dr. Ashwini has already discussed about this, I would suggest there are 2 or 3 things that you keep in mind when you are going for this IOL power estimation. One is hypermetropia should be the norm. The hypermetropia should not be so much that the child is far away from emetropia and amblyopia becomes a problem. And the fellow eye refractive status also gives us an idea that what type of IOL power you would choose for the patient. So single eye a single piece hydrophobic implantation is what we most of the time do. We do a capsulorhexis in these patients, and a manual capsulorhexis often gives a very controlled implantation of the IOL. What we need to remember is when we are putting the IOL inside with the PCC open, we have to be very careful that the IOL doesn't go through the PCC. Multi-piece IOLs can be given in the sulcus, but you should make a optic capture so that the IOL doesn't move inside the eye. So, but there will be special cases like you have a JIA or a JRA with glaucoma and anterior segment dysgenesis. These patients, it's better not to go for a primary IOL implantation. Even if you go, there will be chances that they will end up with secondary glaucomas, band keratopathies, and that should be our relative contraindications. Microcornea, you can go for customized IOL. It is available. You can get them made by the companies, and they are available at a reasonable price in India. So a special mention of uveitic patients. You have higher incidence of hypotony, cystoid macular edema, pupillary membranes, optic disc edemas, band keratopathies, and many a times the patients may need a IOL explantation. So it has to be decided on case-to-case basis and with the severity of uveitis. Ectopia lentis is another case where syndromes are there like Marfan, Will, Marchesini, homocystinuria, and these microspherophakias. These patients have to be carefully evaluated systemically and ophthalmologically before taking a decision to do surgeries in these patients. Traumatic dislocation is another type of cataracts where we will get a problem with IOL implantation. And in these patients, scleral fixated IOL at a later age would be better, depending upon case-to-case basis. Thank you very much. I would be ending my show.
Thank you, Dr. Anuradha. I think that was very short and crisp and to the point. And actually, it's very important, especially these tricky cases, IOL implantations, when to, put the what power to use, what type.
Yes.
And especially these unusual atypical cases, as you told, they become a major challenge. So if there are any comments by the panelists, any comments? Otherwise, we can just have a nice screenshot group photograph. If everybody could just switch on their, videos, then we can have a nice screenshot. I think very few are left. So Even Ashwin.
I think we two are left.
We two are left, so we can have that screenshot then.
Okay.
So, yes. And I've taken that screenshot. Thank you all for joining us for this session.
Thank you,
And
Rebecca.
it was a great pleasure having you all. Thank you all.
Bye bye.
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 Recording stopped.